Hello there. So we are going to have Dr. Lockwood join us in a minute, but I thought I would give some sort of introduction to um, him before he showed up. Um, I've I don't know when I first started following Dr. Lockwood, but I think it was a while ago. Anyway, he got into a little back and forth with Matt Walsh. And previously, I um, did something about Matt Walsh. Matt Walsh has these hot takes on things that are not well informed, but tend to be um, tend to have a kernel of good criticism to them. Um, and here is Dr. Lockwood. Hello, Dr. Lockwood.
Howdy.
So I was just explaining your little interaction with Matt Walsh.
It
Uh,
was fun.
yeah. So I saw that you had some interactions with Ryan Rogers, who I previously interviewed. I don't know if you were on his. You went on his stream as well.
Yeah.
I think that's where I must have initially seen you. I love your Twitter, I have to say. I was just looking at it, trying to figure out, things we could talk about. And frankly, I have to say, just follow Dr. Lockwood.
Thank you.
um, yeah, so I try to keep things pretty informal. I'm just, you know, I there's a lot of stuff I would like to talk about, but
Sure.
whatever you would like to talk about, but just your interaction with Matt Walsh. Um, just I personally kind of feel like some of us are um, are fighting a two-front war where the American Psychological Association and the National Association of Social Workers and some of the other professional organizations, we're going through this postmodern phase where I have professors doubting the necessity to use the DSM and diagnoses and things like that. And then we get people on the other side like Matt Walsh,
hmm
who similarly, they see no real use to therapy. One of the things you tweeted out that a few people seemed to be surprised about, but I really liked is you said somebody asked, are you saying that um, people shouldn't go be in therapy if they don't have a diagnosis? And you're like, yeah, why would they be in therapy if they don't have a diagnosis?
Yeah.
And I totally agree with you, but it
Right.
seems a shocking thing to say to people. And there's way too many people in the profession who are like, yeah, everybody should be in therapy.
Yeah. I mean, gosh, where to start specifically? So, a lot of the people that had a reaction to that, I completely understand the reaction because when I was much younger, I also thought that therapy was this really ubiquitous intervention or service, if you want to call it that, because it is technically a business. So it's a service, and all of healthcare is a service and it's a business. So, from the perspective of could people actually get something out of therapy even if they don't have a diagnosis? Absolutely. I would be, unless you're a terrible therapist or just a mediocre idiot, you probably can help people who don't have a diagnosis, right? I
Right.
think that so there's a question of can you help people? Are you capable? Is it technically possible to help people that don't have a diagnostic issue? Of course, absolutely. A good psychotherapist, whether they have a doctorate degree or a psychiatrist or whatever, it doesn't even matter what the degree is. But like a good therapist, if they're appropriately insightful, they have good boundaries, they understand countertransference, they can give people access to a relationship which changes the way they see the world and see themselves in the world. And that's true for people with a very severe illness, people with a mild illness or people with no diagnosable illness. So my statement was not, could therapy help people? My statement was, what is the specific purpose of psychotherapy? Why was it created specifically? Right? And even if you go all the way back to Freud, for all of his flaws and his failings, Freud wasn't talking to just everybody, right? Freud was talking to people who were very ill, right? People with, one of the most famous case studies that Freud ever published is about Anna O. And Anna O is a case of hysteria. Now, superficially, what that means to most people when they hear the word hysteria, they think something sexist, et cetera, et cetera. But really what Freud got to at the bottom of that case study is this is a person who had no voice because of all the cultural, and in her case, I believe it's physical trauma, sexual trauma she experienced. So Freud was trying to treat people with trauma who were marginalized in, Victorian era Vienna, right? So he wasn't exactly a feminist or anything, but like he was one of the first people who said maybe women internalize their feelings because they're not allowed to talk about their feelings because this is Victorian repressive, Europe, right?
Okay.
And so a lot of people will go inward and they'll internalize and use defense mechanisms to ward off anxiety, trauma, fear, anger, which comes out as hysteria, as opposed to actually dealing with the trauma and things like that. And so for all of his faults, he was the first one to say maybe women are traumatized at an alarming rate, and maybe they should be given a space to talk about all the things that have made them hysterical, essentially. So Freud wasn't just talking to rich women or rich people or whatever. He was talking to people that had serious illnesses, personality disturbances, PTSD before it was a thing, etc. And so that's how the profession started. The early neurologists in the 1800s in France and in Germany and the UK, they weren't just treating people who were like the worried well, as we understand them, whose lives sucked, who had a
First
job they
world
didn't like.
problems.
No, there were no first world problems in the mid 1800s. They were treating the people who were floridly psychotic or had what we now call bipolar disorder or serious depression. Those are the people that made it into psych hospitals back in the day. And so psychiatrists and psychologists of the late 1800s, early 1900s were treating people who were moderately to severely ill. That's how the profession started. It didn't start as this like pseudoscience where you talk to your best friend as a therapist kind of thing. And so for me, it's kind of confusing why people want to talk to the worried well. Like, yeah, they're better clients because they're not so severely ill. And now you've got like a paid best friend, right? And so like you have infinite customer retention.
It's lucrative.
Yeah. And like, are you still possibly helping people even if they don't have a diagnosable illness at that time? Yes, you're probably still doing something useful for that person. Is it maximally ethical to work with the worried well? No, not remotely. Because in my opinion, if you actually read our ethics code at the American Psychological Association, we are not really supposed to work with people who are not actually ill. Because there's a difference between being mentally ill, having a diagnosable condition, versus group 2 of 3. Group 2 is people with really shitty lives who are very stressed out, who aren't necessarily diagnosable, but their life is hell, and it would be awesome to talk to somebody. That's group 2. And then group 3 is the genuinely worried well, whose lives are pretty good. There's no serious impairment. There's no moderate to severe distress, but life is kind of challenging like it is for everybody. And it'd be great to talk to somebody. That's group 3. So group 1, obviously mentally ill. Group 2, life sucks disorder. Group 3, life's pretty good, but it's nice to talk to somebody.
Yeah.
Like I can see the case for group 2. I can see zero case for group 3, ethically speaking. However, there's a lot of clinicians, licensed, etc., who treat group 2 and group 3 all the time.
Yeah. Well, I'm getting a master's of social work, and I can kind of say, seriously, the social work profession is supposed to work with group 2 as well.
Yeah. Of course. Yeah.
Yeah. But No, I completely agree with you, and I think so. I One of the things, it's the economic state. It's easier to work with people who aren't genuinely mentally ill,
Of course. Yeah.
and
More
so
fun. You get to, like, I always tell my students, it's like most of you got in this profession because you like a good story. You're
yeah,
hooked on stories, and people sit there in therapy and they tell you a story about their week, their childhood, whatever it is, and that
yeah.
gets you emotionally, empathically inclined. And now you're like in. Sorry to interrupt, but like I'm with you.
No, I please. I The fact is, on I think we're just going to sit here agreeing with each other a lot,
I don't know.
and in a sense, just a little bit kvetching about the state of the profession, because the fact is that people who are working with the wealthy, sorry, that's a new term for me, but I think I'm going to use it. Um, they, it's lucrative, and a lot of people, that's what they want to do as therapists. But I mean, that's life coaching. That's not being a mental health professional, and uh, confusing the two causes all kinds of problems, not least of which is, for example, a lot of the criticisms that were being leveled at, well, you specifically, um,
Yeah.
because Matt Walsh was like, well, this guy's a therapist. Of course he's going to say, right?
Yeah. And I mean, I just wish any of these people would just listen to my podcast that I do every Saturday,
Mm.
where I basically shit on the profession in a formal professional way and talk about ethics and boundaries and science and the research. Like, I am like the biggest critic of the profession that I think exists
Mm.
currently. And I'm not famous or something, but like I am probably the only consistent voice online, on YouTube, on Twitter, who is just trying to like promote rational skepticism about what the profession can and cannot do ethically, what we are designed to do, how effective our interventions actually are,
That's
you
another thing I
know?
loved. I loved about your. I mean, just today you were tweeting about things like, oh, well, what's the treatment effect, and double blind studies, and scientifically evidence based empirical research into psychology.
Yeah. Yeah. I mean, I am a single issue voter when it
Yeah,
comes to this. Like I'm a very, I'm not here talking about politics. I'm not here talking about she's got great genes. I don't give a shit about any of that stuff. My whole get down is what can I do to protect consumers, empower good clinicians, and keep everyone as scientifically grounded and ethical as possible? And I am not some kind of speech police person, obviously. I am a your ideas suck because they're not based in reality person.
right.
Right. So my criticism is to protect the consumers and protect the profession because clearly the American Psychological Association has failed to have any credibility in the eyes of well over half of the people with my degree,
Yeah.
at least. And so it's a tragedy what has happened to the profession. And it's not that it's like all of a sudden different. It's just been going downhill steadily for 30 plus years. Since the mid 90s, it's been going downhill.
I would
And
say it's been since the '60s, but that's my, yeah.
I mean, comparing it to the 60s is kind of unfair in my opinion, because back in the day, you could like do drugs with your patients and sleep with them, and people wouldn't like it, but you could get away with it. And
Mm,
so I think there were a lot of problems in the 60s and 70s, to be quite honest. I think that we've tried to tighten things up from the 70s through the 90s. And I think that standards have started to slip, and intellectual honesty, scientific rigor have started to become less and less important, especially since the early 2000s. Like when the American Psychological Association helped the federal government torture people in Guantanamo Bay, I kind of lost all respect for the APA. I remember being at one of the APA conventions in the early 2000s, like 2008, 2009 in
mm.
Boston, and just looking at the people in charge. Like I met Zimbardo that time, and I was just like, boy, none of you have a shred of any ethics or dignity. And like, I can't believe that you're still teaching and shit. It's just absolutely wild to me. And I'm no like stellar scholar or scientist or anything, but like, God, you tortured people and like did a bit of a couple of mea culpas about it, but you're still out there pretending like you're a decent guy. It's wild to me. So it's just like all these people who've given up
Well, I
and
think
sold out.
I think a lot of it has to do with postmodernism, and if you don't have a you don't have an ethical core that you're operating from, then you can rationalize basically anything you like.
I think it's convenient to blame postmodernism and things like that, and I can sympathize with it to some degree. I think it's more complicated than that though, because something that I talk about on my podcast is you have to look at the bigger, broader picture of the profession too. So there's
Mhm.
the academic side of it, which is, what are the trendy ideas in academic science, including postmodernism, whatever woke boogeyman kind of thing. But then there's also these other incentives, right? Because as you probably know from your graduate program, like humans are motivated by multiple incentives simultaneously, right? And so people are motivated by social status and pressure, academic stuff, but we're also motivated by money, right? We're motivated by fitting in and things like that too. And so, like from the money side of it, the profession has basically been crippled by the Affordable Health Care Act, because once everyone had to have a certain type of insurance and once you had to mandate that
Mhm.
healthcare companies cover psychotherapy,
Mhm.
now all the incentive systems around money shifted drastically in the mid 2000s in the United States, at least. And
Interesting.
so,
So how exactly? Because I'm actually my previous profession was an insurance broker, so
oh,
I'm
okay.
really into this stuff.
Love
But
it.
yeah, so what is this shift you saw?
Well, once you start to put healthcare companies, which I think is at least a tongue-in-cheek phrase at this point, but insurance companies, to be more specific, they have an incentive, which is to pay out as little as possible, typically speaking, especially for mental health services.
Right.
And so, as opposed to the Affordable Health Care Act increasing access to treatment and healthcare services in the mental health world, what it's done is it's increased access to a certain type of treatment and healthcare services, not all providers, because the people that are trying to do good psychotherapy often don't take insurance for the very obvious reason that the reimbursement rates are fucking abysmal, to be
Right.
precise about it. And
Yeah.
so you're missing out on a quality of healthcare because of the type of reimbursement that's offered. And so, very few quality providers, not that there are zero, but the proportion of excellent, top notch providers across any discipline, whether it's individual therapy, couples therapy, family therapy, that are taking insurance and doing a good job, it's very rare that those folks are paneled with Anthem or Blue Shield or whatever it is. And so what you're going to find are mediocre or less than quality people who aren't good business people, who don't have a good backbone, who aren't ethical in some ways, probably. And that does not say the cash providers are super ethical, because many of them are greedy narcissists who think they're amazing and should never take insurance, just to be
Yeah.
clear. So I'm not trying to create a false dichotomy. But what I'm saying is there's a lot of people who aren't very driven and motivated and smart who will just let insurance do the work for them because they're lazy. And that's all fine, because like it's hard to build a business. I've done it a couple of times in my life. It's hard. So I'm not judging
Yeah.
necessarily, but it's like, what kind of person is going to be paneled with insurance,
So I
right?
mean, I hear the criticism, and I agree with you. It's just I don't see that having changed since the ACA, because before the ACA, like there was less insurance coverage. So I guess the number of people who are providing that low level mental health has increased, but even 20 years ago, the best therapists were not taking insurance.
100%. And now you have more people taking insurance,
Yeah.
but it's probably not any chunk of the best therapists taking insurance.
Yeah.
You might catch an intern or a trainee or a recently licensed person who's really good taking insurance, but the best people are probably never going to be paneled at all
Yeah.
whatsoever. They might do like a super bill, which is awesome. So maybe that's happening more. But I think you're going to get more of the middle of the road people who are paneled, who are taking insurance. And so that means that the quality is diluted. Now,
Yeah.
that doesn't mean it's bad that more people have access to therapy. It's very
Yeah.
good that more people have access to therapy, but they also have more access to more mediocre people.
Well, yeah,
Right.
and iatrogenic harm is real.
Exactly. That's my whole podcast, is trying to prevent that.
Yeah.
Literally.
Yeah. So no, I completely agree with you, and frankly, I have to say one of the things that was kind of disappointing is the lack of quality control.
Oh yeah.
There's a reason why I have when getting my internships, I imagined getting my internship like it would be easy to get an internship, but most
Yeah.
places they're like very like they don't trust the degree programs to actually be screening out people who really are not capable. And frankly, in my programs, I have seen people that was like, why are they just
Yeah.
going to graduate out of this program without
Yeah.
any possibility that this person is going to be a competent therapist?
I know. And I talk about this often on my podcast. I am extremely grateful for the program that I teach at, because their admissions criteria are solid. I've never had a real concern about any of the MFT or PsyD students they admit.
Really?
Yeah. Super thrilled with my program. Super grateful to be there. They treat me well, and they always admit good students. And, you know, we even had an internal discussion about admitting more students. There was a lot of pushback from the faculty about like, what's the quality going to be, et cetera, et cetera. So like, I trust my colleagues implicitly. They're good people who care about quality. Who is the person that we're letting into the program?
Right.
And so one of the reasons that I fight so hard and I'm so verbal online, on my podcast, et cetera, about this is because I've seen both types of programs, and I've seen what happens when you let someone who is too ill, too uninsightful, too stupid into the profession. I see bad things. If that gets me canceled, whatever. But like,
you are even more blunt than I am, and that's very hard to find.
yeah, I mean, it's just, I've seen all three things. I've seen people that are too ill who should never get licensed for ethical reasons. I've seen people who are too uninsightful who are just going to need so much supervision to get some good insight and some good boundaries and countertransference management. And I've seen people who are just not very bright.
Yeah.
And because they're not very bright, they're going to have a hard time picking up on their stuff and, expressions and things like that with a lot of accuracy and consistency.
There is definitely an IQ floor to being a good therapist.
Yeah.
And if you don't have that IQ, because you have to be thinking faster than the person who you're dealing with. If you're not thinking faster than they are, you're going to have a very hard time summarizing what they say, asking good motivational questions, and reflecting things and having insight into their lives. And so, there has to be an IQ minimum. But
yeah,
we're getting rid of standardized tests from all kinds of college admissions. Yeah.
Yeah, I think, I don't think we necessarily need to do intellectual testing to screen out for clinicians. I think there's other ways of going about it that are more domain specific, obviously, like maybe bring back the psych GRE or something. But, I think sometimes programs, and thankfully not my program, but sometimes I've seen students from other programs where they're good people, they care, they want to help. And then because they're a little limited, I just worry that they're going to be able to help as much. Now, maybe life is going to beat them up, and maybe, working with clients will change them and force them to be more on top of things and grow, or maybe work on some of their executive functioning skills. I don't know, but you know, I worry when we're so quick to just let anyone into the profession. You know, the thing that, you know, I've talked with so many of my colleagues of every degree level and every background about like licensure. So
Mhm.
I always think it's interesting that different states have different requirements for licensure. And as much as I'm not a fan of the federal government in any way, shape, or form, I'm a fan of the idea of having a national licensing exam
Mhm.
based upon your degree and your training,
Well,
right? So if all,
that's kind of what the state compact is trying to make happen.
I would love to see that happen. I don't see it happening in the near future because I think different states have different laws. And so, you know, you could rationally make an argument for a national licensing exam, which tests basic competencies. And then if you could add in, if it's possible, to mandate and add in an interview with, you know, because the old licensure exam here in Cali was you had to go before a panel of people, and I think in a hotel room,
Yeah.
and do an oral competency exam in addition to your test, your standardized test. And so it would be awesome if we could bring something like that back, even though it's a very unwieldy process to get a panel of psychologists together to go to the comps exam.
Well,
But
SciPac seems to have done. I mean, other than New York, I mean, New York and California are the big ones. But
yeah,
you guys at least have that with psychologists. With
yeah, but that's not
oh
your
yeah,
competency exam. That's just can you practice across state lines and get a gold seal? That's more of a commercial thing than an ethical thing at this point. But
mm,
I do like SciPact. I think it's a good thing.
yeah,
But if we move towards a federally mandated licensure exam that was standardized across all states and you had a state specific ethics exam, that would be ideal. Because the fact that we have different standards across different states and different requirements for hours, and you know, some don't care if you've had supervised professional experience, and some care if you've had 3,500 or in certain buckets and certain amounts and certain times.
yeah,
And so
yeah,
we should standardize all that. It shouldn't be state
yeah.
specific.
Yeah, I have to say, I mean, I also went to law school, and legally, I that would be a very, very hard sell to the Supreme
Sure.
Court
Sure. I'm sure.
because
States' rights.
because well, yeah, I mean, interstate, yeah, especially with this Supreme Court, I just don't see the Supreme Court going for it because professional licensure has always been a state issue, and interstate licensing, um, yeah, that's. I mean, you're almost talking about something that's legally impossible.
I understand. I understand.
The,
Like,
the
I
way
get the
to do
gist.
it would be like a compact. If something like SciPac had the types of requirements that you're talking about, that would work because the states can decide to do that together. But unfortunately, the federal government's not going to be able to do it.
Yeah,
And
I hear you.
yeah,
I'm not a lawyer for sure. And so, like, you know, I'm speaking more idealistically because, you know, the very progressive part of me is like, we need to protect the consumers. And these state boards are not doing a great job of protecting the consumers, unfortunately,
I
because
totally agree with that.
people in private practices can just go on engaging in unethical behavior, borderline ethical behavior, use you know, treatments that don't really help, that seem helpful because they're fad like. Um, there's just so many like shades of gray problems that can happen in the secret of private practice that never get reported to the board. Even though big problems like sexual assault and dual relationships with patients sometimes get reported to the board, but not consistently, believe me. I've heard
Mhm.
some wild stories
Yeah,
of people that never got reported to the board for just wild things. So even people who do egregious, obviously unethical, illegal things never get reported to the board, unfortunately.
hmm,
And so, like, I would love some nationally standardized requirements
yeah.
for ethical practice and monitoring of your practice. And again, I'm not a fan of the federal government, but like, this is a case where I think Big Brother would be great because some people just absolutely are narcissists and they're dangerous
Yeah.
to their
No,
patients.
there are definitely ways it could be done, and maybe even through CMS,
Maybe.
Center for Medicare Services,
Yeah.
because honestly, if Medicare, when Medicare sets a standard, it becomes a national standard really quickly.
Yeah, sure.
Yeah, that might be a way to do it. I mean, this is the first time I've really thought about it. I'm just not sure. I certainly don't have the reach to actually have an impact on that. Um, so I do want to go back to this idea of iatrogenic harm, and
Yeah, sure.
you were talking about, people trying things which they think will be helpful, right?
Mm,
And I've seen a lot of that where
mhm.
people, and you talked about it in one of your tweets today, actually, or maybe it was yesterday. You were talking about the fact that if you don't have a double blind, right, you could have something with a small positive treatment effect, or simply a placebo effect,
Mm.
and the person might think that it's helpful, but so what do you do with the fact that we have, I mean, I don't trust the publications. I don't trust the peer reviewed literature. I even, I mean, even when I look through the actual research and the
Yeah.
articles, what do we do about that?
So there's a lot to say. And so the professor side of my brain
Hmm.
is always interested in being, appropriately skeptical and critical of every study, about every intervention, and making sure that we're not either hurting people or wasting people's time, for
Right.
sure. And so like there's always the file drawer problem where a lot of the trials that failed, the negative trials, don't get published, so we don't really know, right?
Mhm.
I reposted that about depression the other day or whatever in psych meds. um, so I'm in agreement with you in the sense of there's a lot we don't know,
Mhm.
and so we're going to operate on incomplete evidence at all times, right?
Right.
So in our profession, which is worse off than medicine, even though medicine has the same problem,
Yeah, it does.
we're operating on incomplete evidence.
Right.
And any professor with a spine should be able to say that without any wincing or anything like that. So where I disagree with you
Mhm.
is when you look at the positive trials, right, that
Right.
exist, where ACT worked for this, substance use problem or depression problem, or CBT worked for that, or DBT worked for this, or
Mhm.
motivational interviewing worked for that. Like, I feel very confident reading those trials with all of their limitations,
Mhm.
right? Like one of my favorite studies, I don't have it pulled the authors off my head, but like
Right.
one of my favorite motivational interviewing studies, they went to the Pacific Northwest. I think it was Seattle or something.
Mhm.
And they went to this group home for adolescent sex workers. And
Okay.
they did the impossible, right? So it's one of those fantastical papers.
Right.
So they went into this shelter for adolescent sex workers, and they did a bunch of MI, and they used the trans theoretical model to see what stage of change they're at and all this stuff. And they helped this group of adolescent sex workers increase their condom use, which is literally a miracle because most sex workers don't use any protection or use very little. And
Right.
adolescent sex workers in particular are
Right.
much less likely to because they desperately need the money because they're homeless and stuff, right?
Right.
And so they went to this homeless shelter and they helped these kids take better care of their health,
Right.
right? And so there's actually a lot of motivational interviewing research that's in that same vein of like, we got people with diabetes to take their insulin more. We got people with, like all these chronic health problems to live a healthier life. And
Mhm.
so I know every one of these studies has significant limitations, both in
Right.
terms of study design, recruitment, missing a placebo, missing a control group, whatever it is, all of which is perfectly valid in
Mhm.
threats to internal validity everywhere.
Right.
So I'm 100% on board that all these threats to internal validity exist everywhere. They're all convenience samples. Like 99% of all randomized controlled trials are convenience samples.
Yeah.
Right? There's no community clinic samples that perfectly get a diversity of all backgrounds, ages, genders, like it doesn't exist. It's impossible to do. You need billions of dollars to do these perfect studies. You can't do perfect studies. So what we have to settle for, in very practical terms, are hundreds of imperfect studies.
Mm-hmm.
It's like you can't eat the whole elephant, but you can get little slices of it. And so all of these randomized controlled trials, you shove them all together and you get like a general picture that is acceptance and commitment therapy generally helpful.
Mm-hmm.
Yeah, absolutely. But is it generally helpful for all people with depression? No.
No,
Right?
I mean, I don't want, I certainly don't want to overstate the case. And I do think there is a propensity to say, I mean, we saw that with the CAS report. I think a lot of people were saying, hey, you're throwing out all of these studies and it's too skeptical. But the fact is, I mean, too many times when I look into a study, and I just don't trust. There are just too many journals that when I end up reading the actual study that we're talking about, like sometimes it's just like, wow, did they do any actual review of this? I've posted, so we have a little community here, and I've actually posted things to the community, just like, this is a peer reviewed study and it was literally worthless.
Yeah.
Literally worthless.
Yeah.
And I think that really is part of what's making people be very skeptical, you know?
Yeah. And I think that is normal as a reaction. So the problem that I have with that reaction is that we're missing the bigger picture, right? And so if you were to look at other types of comparable professions, right, whether it's economics or sociology or psychiatry or other parts of medicine, you would see many just absolutely throwaway garbage studies. I don't even know why they did it, right? And the thing that I think is, okay, if we look at this big picture, what is the entire point of the empirical approach to the social sciences, right?
Yeah.
Because it's the social sciences, not engineering, mechanics, chemistry, not a hard science, right? Hard sciences have fewer parameters, easier to do true experiments. Social sciences, real experiments almost never happen.
Right.
Statistically extremely rare, especially in clinical psychology. The best we can hope for are good quasi-experimental or random control trials, right?
Yeah.
You can't go abuse a kid and see what happens to them. You know what I mean? It's
Yeah.
cool. It's a little unethical, a little
Just a
Mengele.
tiny bit. Yeah.
Yeah. And so, like, I trust that because we are so limited in what we can do, we have to be okay with the fact that we are limited in what we can do. And so that's why we need hundreds and hundreds of studies are published every year. Because the more people we have going at this big behemoth of a problem, right? The human mind, human behavior is so complicated and complex that until we have millions of more studies, we can't say a whole lot with a lot of certainty.
Yeah.
And so the professors that I hear talk with absolute certainty bug the shit out of me. Because if you're a real scientist, if you understand statistics well enough and understand all the different limitations scientifically to all these studies in CBT, ACT, DBT, etc., then you should never talk with a great deal of confidence. You should talk with some humility and some confidence because that's reasonable, right? And so I don't expect there to be the perfect DBT study or the perfect ACT study or the perfect psychodynamic study. What I expect are dozens and dozens and dozens of moderate quality, peer-reviewed, randomized controlled trials, sometimes with a placebo, sometimes with an active intervention, whatever, that give us some more certainty, a half
Yeah.
a percent more certainty over time.
Yeah.
That's what I would expect. And I think that's reasonable, right? I don't expect for there ever to be like this perfect causal explanation, because I think anyone who believes they perfectly understand the cause of mental illness is lying.
Yeah.
They're lying, because
Or,
every human
or
being,
diluted.
or deluded. Yeah, they're so smart and brilliant that they perfectly see the trauma that caused all your shit, which is not true, right? Like everyone has this weird interplay of social determinants and genetics and current stressors and past stressors and family of origin, templates in your brain and attachment stuff. There's probably at least a dozen different variables that predict your mental illness at any given time.
Yeah.
At,
Yeah.
at least to being like conservative about it. You know, sometimes, yes, the meth caused the psychosis and the psychosis was triggered, and now you have this genetic predisposition that's now permanent, right? That's a rare thing that happens. But most of the time, it's multiply determined by multiple variables all at once, right? Like one of the things that I'm really excited about is that a lot of these psychiatric conditions are now being considered neurodevelopmental, because we see prodromal symptoms earlier in life, bipolar, schizophrenia. Many of these things you can see early warning signs
Mm,
that aren't
interesting.
full-blown symptoms. You're not having a
Yeah.
full-blown manic episode at 12, but
Right.
is your kid extra talkative? And is that pressured speech or flight of ideas showing up at 12 or 13? And does it become bipolar at 16 or 17 after drugs, trauma, stress, right environment, whatever it is, right? Like that kind of thinking I'm super excited about, because the more we understand the developmental nature of some of these issues,
Yeah.
the more we can see how complicated it really is.
That sounds really interesting. I'm not aware of this stuff. Yeah, I'm gonna have to look into it, because yeah, I completely agree with you. You know, sometimes you end up, a lot of times, what I have found is people have their pet theory, and
Yes.
they imagine that their pet theory explains everything for everyone, and you know, which I mean really does get into, you end up uh with therapists having a particular
Mm-hmm.
methodology that they're very into,
Sure.
and when it comes down to, okay, is this what this particular client wants, I don't see a lot of um I mean, it's my experience. Maybe there are people who are doing this, where people are referring, okay, you know what, for you, maybe a more, I don't know, logotherapy or psychoanalytic or Jungian or whatever, right? Um, would make more sense than CBT, or
Yeah.
you know, um, and that's one of the big things I dislike, is we seem to be leaving it to the the patient, who's the least capable person, to choose what the methodology is for their intervention.
Yeah. I think that sometimes happens. I think the question then becomes, you know, what is the best standard practice, right? So for
Mhm.
me, my approach, thinking of my ethics code pretty frequently, is, you know, what is informed consent, right?
Mhm.
So one way that I teach about informed consent at the university and when I supervise interns is you have to be able to actually genuinely explain the potential interventions fully and their pros and cons
Mhm.
in order to actually have done informed consent, right? If
Right.
informed consent is I do this one thing
Mhm.
and it alone could help you, then you actually haven't done informed consent correctly. Now, the limitations to that statement include, like, well, if you're a trainee at a clinic and they're teaching you how to do ACT,
Right.
then yes, that's the only thing you're allowed to do because you're a trainee, right? So that's a fair limitation. However, if you work in rehab or if you work in private practice or community clinic and you have the capacity to use different interventions and you choose to not discuss other potential interventions that actually could help that patient, then you're not doing informed consent appropriately. And that means you're failing to live ethically and act ethically as a clinician, right? And so for me, I think first and foremost, what exactly is informed consent? It is telling the patient to the best of your knowledge. Now, your knowledge might be limited. I don't expect people to be perfectly brilliant and have this encyclopedic knowledge of everything in the research. Most people are not professors. You know, I had a great coffee this morning with one of my colleagues who didn't know a lot of things, and he's a really good guy, and I would trust sending all sorts of patients to him for his specialty.
Yeah.
And he's also a little limited because he's not a professor. He was trained once upon a time, etc. So he's got like his pet theories that he uses, and he's good at them. And so for the people that I think he's good for, I will refer them his direction.
Right.
No question. I trust
Yeah.
him. However, he's not going to provide a menu of options for the particular presenting problem that he's good at. Right. So I don't have a problem with the way he practices. I wish he was more curious and learned all the different types of interventions that could help patients. And he's actually interested in learning more, which is why we met. And we had a good conversation about other things he could look into. But like, I expect a lot of people to not be super smart, super driven, rock stars who know, like, if we just pick one clinical problem, let's call it trauma, right? PTSD. There are 6 or 7 evidence-based website of what has been like.
I think we're losing your connection.
Oh, okay. Let's see what that's about.
Yeah, sorry.
Sorry, but like
missed you for a little bit.
Yeah, like evidence-based interventions. There's multiple evidence-based interventions for PTSD, including cognitive processing therapy, EMDR, prolonged exposure therapy, virtual reality exposure therapy, narrative therapy, trauma-focused CBT. That's 6 right there.
Yeah.
And so all of those interventions are to some degree helpful for people with PTSD. If you know only one of those things, and I'm an EMDR therapist, which is all the fad now, no shame about that, because EMDR is basically just exposure therapy. So great. You know, it's another type of exposure therapy.
Yeah.
And so like, would it be better if you also knew cognitive processing therapy? Yes, absolutely. But like, do you have to in order to be a good therapist? No. You're just not going to help the people that would be helped by cognitive processing therapy instead, right? And so my hope is your informed consent process is very clear, both in a written sense and in a verbal sense, about what I know, what I believe will help, and why I think it will help, what I don't know, and what are some alternatives in case you don't want to work with me based upon what I know and don't know.
Well, I think that's the big catch there is in terms of alternatives. I mean, what you were talking about, okay, you had coffee with this colleague, you better understand what that person is capable of and what they know in terms of their methodologies. I just, in my experience, I have not seen a lot of people referring. I've seen some of it. I've definitely seen, people being like, "Hey, maybe you might want to try CBT," or, and I mean, there's like the Jung Center, not too far away from me here in.
Sure.
I'm on the west side,
Sure.
but yeah, I guess I have not seen I've not seen the type of professional referral system, the type of I what I have seen is some people, I can't say everyone, but some people have a propensity to, okay, this is what I do, and anyone who comes through the door, this is what I am going to be offering them. And it just seems to me that leaving it to the client to decide which methodology is
Yeah.
best for them oftentimes puts more demand on them than really they're capable. I mean, yeah, I can learn more than one methodology and know at least about methodologies that I am not going to be practicing, but like explaining to someone, hey, well, okay, this is what the CBT is, and this is what EMDR is, and then expecting them to choose, that's where I think it's actually problematic.
Yeah, I think some people operate that way. I don't know what the proportion of clinicians are out there that do that. I
Yeah.
think I would err on the it's complicated side of things because in my experience, obviously, I've lived a very convenient sampled life working mostly in rehabs. And I have a small private practice where I do family and couples therapy too, but that's like very, very part time, very niche kind of thing.
Mhm.
Um, but like my experience in Southern California for the last 15 years has been the people that I generally have talked to, especially where I've worked on the west side of LA and Malibu, Thousand Oaks. Um, and I've
Well,
had some good
Malibu is where
colleagues.
the very expensive rehabs are.
Yeah, no, definitely for sure. And but I know a lot of people all over Mid City, Mid Wilshire,
Yeah.
Hollywood, downtown, Silver Lake, Pasadena. And
Mhm.
my experience is that people tend to be very specific and strategic in their referrals. And
Mhm.
part of that is like, who do you know, right? Like, who are your friends? Something that's very important. I tell my grad students all the time is these people that you're graduating with, these are your referral sources. So make sure you have an actually good relationship and you're clear about what your strengths and your weaknesses actually are before
Mhm.
you go out there.
Yeah.
Like you can always get a little bit of an interesting kind of voyeuristic look at this if you join LACPA. I don't know if you've heard of it.
I have not.
Yeah, so LACPA is the Los Angeles County Psychological Association.
Okay.
So like many of these professional associations, they have their own listserv where people email out topics and have conversations about things. And, they're pretty good about when there's a referral
Mhm.
that they specifically are very clear about the types of provider, types of presenting problem that the person might do best with gender, age, background, all these things, type of interventions they've tried, not tried. So I feel at least decent about what I know in the psychologist world
Yeah. Yeah.
about that. I have no clue if it's different for, CAMFT or MFTs or whatever, but like I've seen mostly my colleagues of all degree levels be very intentional and specific in their referrals.
Yeah, I think you might be seeing a lot more development, which makes sense on the PhD level with psychologists than necessarily what I'm seeing with LCSWs, LMFTs, and LPCCs. Yeah.
Maybe. Yeah, I don't know. I mean, I have plenty of good, like in my little office suite here, I have 3 LMFT colleagues,
Mhm.
4 that are very specific, very specialized, and they make very specific specialized referrals because I'm in a couple of group threads with them and I see the way they talk about referrals. And it's not just they're sending people to their friends, they're like, this person might need this kind of personality and things like that. So I don't know. I also come from a very different age group than you do. I think a lot of the younger people might be operating differently than some of us that are older millennials, Gen X, and those kinds of people,
Yeah.
potentially.
Well, I'm an older student. I'm actually pretty old, uh, but
Well,
yeah.
but your
Um,
colleagues are usually on the younger side, I imagine.
uh, um, to some extent, I'm doing an online program, so they also tend to be. In fact, I mean, in my program, the other students tend to be people who have been, for example, working with the county wherever they are,
Yeah.
and now they need to get their MSW to
Yeah. Yeah.
progress, that
Yeah.
type of thing. So
Yeah.
it's a little bit different than I think you get a lot more with psychology and even MFTs of people, getting a bachelor's degree and then immediately going into a master's or doctoral program.
Okay.
Yeah, but I mean, look, Los Angeles is a very big city, but I do have to ask you because I've also been taking classes at the substance abuse, the addiction studies classes at Los Angeles Pierce College,
Okay.
um, because frankly, some what I found is some of the classes are absolutely excellent. Um, so I'm wondering, what do you think of that the whole substance abuse counselor at uh, there's a lot of peer counseling. There's,
Yeah.
how do you feel about that in for the profession?
Yeah, I mean, I've spent the last 15 years working in rehab, so my experience is
Mm,
kind of like with licensed psychologists and psychiatrists and MFTs and LCSWs is there's a diversity of people who apply to those programs, and their skills and their training and their insights are different. I think one of the major differences that I've seen just demographically is a large chunk, not all, but a large chunk of people that get those credentials like RAD-T, KDAC, etc., are people that maybe aren't interested in going and getting a master's degree and they want
mhm.
a somewhat quicker approach. Another substantial difference I've noticed is that a lot of these people are earlier in their sobriety if they're sober. And so they're 6 months clean, they're 1 year clean, something like that. And I don't have any judgment about that. It's just that if you are still fairly earlier in sobriety, there are certain obstacles that you might face compared to someone who maybe isn't in recovery or maybe isn't severely struggling with a substance use disorder. So the different types of people have their pros and cons. And I've seen some awesome rad T's and KDACs in my career. I actually just hired one for one of the programs that I'm consulting for. And so I'm really excited to work with this person and kind of help mentor them and get them in shape and, in their lane kind of thing. But I've also seen some people who should never have a credential and never work with patients. And so and unfortunately that's a lot like LMFTs and LCSWs and LPCCs and psychologists and psychiatrists. I'm
Yeah,
surprised any of these people are licensed sometimes.
yeah,
So I mean, I what I like about it is it gives people who aren't sure if they want to spend all the time and the money to go get a degree an option of getting in the industry and starting to help. I like
yeah,
that. I think there's a drastic shortage of qualified people who care. And
yeah,
so it is to some degree just a numbers game. Can we get more people some credential that helps? But the problem is it takes almost nothing to get your rad T.
yeah,
And so because of that, you got a lot of people 6 months clean, not very mentally stable, life's kind of a mess, getting their rad T, who might relapse while they're doing their job, who might have a psychotic break or whatever it is, et cetera, while they're doing their job. And it's okay to be ill. It's not okay to risk the patient's well-being with your illness, right? And so really the question for me is, who's supervising those people?
yeah,
And are they managing them well? Right? Because it doesn't matter that you have this, that, or the other illness or diagnosis.
mm,
You're welcome in the profession, no matter who you are, as long
yeah,
as you're okay and you can do the job okay. Right. And I just worry about the relative quality of the supervision of these people because most people just hire so we can fill bodies and get groups done and things like that. And that's not a great ethical way to hire. The reason that I have a pretty good reputation, believe it or not, despite all the crazy things I say online, is because I'm known as that, nasty, loud, annoying person who's like, are they actually okay?
yeah,
Are we going to do this the right way, or are we going to just hire people? Right. So my reputation actually matters a great deal to me. Boots on the ground. I don't give a shit about my online reputation, but my boots on the ground reputation matters a great deal because, if I'm known as the guy who just you know lets you hire anybody,
yeah,
then my reputation sucks.
yeah,
And you're going to do shitty work with people, and you're going to hurt patients, and heaven forbid, insurance is going to come after you, right? So I want to do it right,
yeah, yeah, yeah,
and I don't see a lot of people interested in doing it right. They just want to hire people and get it over with.
yeah. No, I completely agree, and I've seen pretty much the same thing. So I initially started taking classes at Pierce because it was the easiest thing to start off with, and my
Yeah,
professors very quickly told me, um, "What you want to do is get a master's degree," and I already had
right.
a bachelor's. So
Yeah,
I started my master's degree, and the reason I went back and started taking classes again in the substance abuse course was there are just some really great professors, and I found the classes to be a lot more educational,
Okay.
but at the same time, then even my master's degree course, but at the same time, I saw a lot of what you're saying, which is a lot of people who are in recovery, and for their recovery, they have to be in some sort of job um job training program, and so it naturally becomes, or they get a job actually right after recovery doing uh, some sort of peer work at wherever they are, which
Yeah.
then requires them to take courses.
Yeah.
And yeah, I what I saw was basically the exact same thing you just said, which
Yeah.
is there are some people who are really good and I am sure are going to be very successful.
Yeah.
Um, and there are some people who obviously the program should weed out. I believe the educational program should weed out, but the educational program really doesn't.
Yeah,
Yeah.
that's not the business model. The business model is get as many people in as possible and, make sure they take the ethics, CE and they're on board with it. And I think that one of the major problems in mental health care is, ethics comes second, third, or fourth, and business comes first. And I'm a businessman, so I want to make money, and I have no problem with making good money. What I
Yeah.
have a problem with is ethics appears to be something that we have to do. So the attitude universally across all degrees, not
Yeah.
just, KDEX and rad Ts, but like I know psychologists who think this way. I know MFTs and LPCCs who think this way, where it's like, I hate that I have to care about ethics. I hate that I have to explain informed consent. I once had an intern who like thought it was a chore that they had to explain that they had a supervisor. I'm like, bro, it's my license. Let's not fuck up my license, shall we?
Yeah.
You know? So it's just, I think doing the right thing is uncomfortable and it makes you have to look at yourself. It makes you have to think with humility. It makes you, if you're doing it right, you have to be, um, or people think that if you're acting ethically, you can't be your best self or you can't kick ass or be special. When in
Yeah.
reality, I think you can also be special and be ethical,
Yeah.
right? So even if you're a little personality disorder, you're a little different, you're built a little differently, I think you can still be super ethical.
Yeah. Yeah.
Like I think there's so many ways to be different and special and make money, but also be ethical. And I think that a lot of people in the profession, they have like a poverty mentality or they have their own personal mental health issues that keep them from getting over the fear-based hurdle of trying to do the right thing. Or they don't believe in themselves, so they're lazy. Or there's so many, I think, valid reasons that I don't like, but they're valid, that people choose to do what is convenient and be imprecise in their speech or just kind of like look to the side, look away when something unethical is happening, right? Like, I don't, I can understand all the human reasons why it's not popular and sexy to care about ethics first and business second.
Hmm.
And at the same time, there's such good reason to care about ethics first.
Yeah.
And actually, it'll make you stand out. You'll be special. You'll be like me, where it's like, here, there's that annoying fucking psychologist and professor who's like, do it right. Don't just do whatever feels right to you.
Right. Yeah.
I'm literally special because of that.
I think, unfortunately, a lot of the economic incentives are not set correctly. And when people recognize that, yeah, professional reputation matters,
Hmm.
And if we as professionals are maintaining uh, our standards and our reputation, that it will that will also economically benefit all of us. I think a
Yeah.
lot of people do not see, kind of really policing our own profession the way you seem to be doing, and I hope to see more people doing. They don't see it as reflecting on their personal reputation, which they should.
Yeah. I think that, just to be very clear for everyone who listens to this, I don't want this to come off like I think most of the profession's bad. I actually disagree. I think most of the profession are just ordinary people
Hmm.
who would like to help, etc.
Yeah,
And I think they're probably average with regard to ethics, and maybe even a little above average because you have to go through all the testing and the licensure. So you're annoyed and you're like, well, I can't screw it up. Right. And so, like, I would say that on average, most therapists are probably a little more ethical than the average car salesman or whatever.
yeah.
But
Certainly, insurance salesmen. I have to say, I've seen much worse things in insurance than I have in mental health.
sure, sure. And me too, in other professions as well. And so, like, I'm not here shitting on the profession saying it's all screwed because everyone's mentally ill or everyone's unethical. I don't believe that for a second. I believe most people are just like decent, regular people who are a little more interested in helping. They care a little more. And I think that there's just more we can do to elevate the status of ethics and being precise in what we say and what we believe is true and can work and not work, etc., so that people have more confidence in the profession again. And people like Matt Walsh don't have a fucking podium anymore about this
Yeah.
topic. He can have a
Yeah.
podium about anything political. I don't give a shit. But he should never have any street cred about anything that we do.
Yeah, no, I completely agree with you. The fact is, I mean, he does this with pretty much everything he does. His job is hot takes,
Yeah,
and he oftentimes is talking about criticisms that a lot of people have, which many people may be afraid to voice. You know,
sure.
um, you know, for example, you brought up. It, it I think it's undeniably true that a lot of people who have interest in becoming therapists, it's because they have a history of having mental health issues themselves. And
Sure.
I don't think there's anything strange about that.
No.
Um, but like you said, if you're currently having mental health issues, then maybe you should not actually be a therapist right now
Right.
until you're further along in your recovery or remission or whatever it is.
Right.
Uh,
That's literally on our licensure exam. And every year, 2 years when I renew, it says, are you impaired by medical conditions, mental health issues, drugs,
mm,
in a way that would inhibit your ability to practice ethically? Right.
yeah,
So they ask a question at least, you know. So every 2 years that you can lie, I guess, you
yeah,
know.
yeah, yeah. I mean, Um, I do wonder what we could do. I mean, I don't know if you heard about the consent decree that happened with Los Angeles Department of Child and Family Services.
No, what happened?
So they used to screen all of their social workers for mental health issues,
Okay.
and two of their interns actually, I think it was interns, sued for ADA compliance,
Ah,
Americans with Disabilities compliance, and the suit got pretty far, and um, so there was a consent decree. Like they agreed as part of the thing to not do that anymore,
yeah.
and it was like, really? Are we really going to say that Um, there's no general interest in screening whether the person currently has a mental health issue in hiring clinical social workers.
Yeah, that will, I think, pretty quickly violate ADA, because mental health issues are, you know, known valid disabilities. So, you know, if you know, I don't know if you've ever looked on Indeed, but I post Indeed ads to help hire, etc. And like, if you're going to do a screening, you can't not hire people specifically because of a disability,
Right.
right? You can say yes, no, or I do not wish to answer, right?
Yeah.
Legally, ethically. And so, yes, they can screen you out technically,
Mm.
but if it's specifically because of the reason of having a mental health diagnosis, then you've now violated the ADA. And so the problem we have legally and ethically is we never want to discriminate against people with a diagnosis, right?
Yeah. It's
Because
not the
I've seen,
diagnosis that is the problem. Yeah.
right. And so the question is their diagnosis active and impairing,
Yeah.
right? And active, I'm even a little less worried about to some degree, not completely, but to some degree, than is it impairing. Because if you have a history of depression and you happen to be a therapist or whatever, case manager or LCSW, whatever, that's okay. And even if you're still working on your depression, that's okay, so long as you can ethically do your job, get supervision and consultation to help manage. Like, I had a patient, excuse me, not a patient, I had an intern once
Hmm.
who had a valid diagnosis of bipolar 2, and a psychiatrist screwed up his meds.
Oh wow.
And because of that, he was having subclinical hypomanic symptoms. He was irritable and all these things.
Mm.
And he was still capable of doing his job. He needed extra support, and we gave him extra support and things like that. So, like, I have all sorts of compassion and grace for people being ill
Right.
and needing extra help. But what is not okay is if you're lying about your mental status to
Right.
continue working. That's not okay, right? And so the legal problem we have is we can't just say because you've had a diagnosis or maybe you scored higher in some random screener, right?
Right.
Like that's not really a good way to actually formally assess if someone's doing well,
Yeah. Yeah.
you know? So I'm kind of with those people who sued in the sense of, you know, you're violating the ADA and there's no informed consent, and like, what if I'm just temporarily struggling with anxiety or trauma symptoms or depression symptoms, and like 2 weeks from now I'm okay, you
Yeah.
know?
No, I mean, I certainly, I mean, frankly, if you were to make having had a diagnosis an absolute bar, you would not have enough people to be therapists.
Yeah, we'd be out of clinicians of all degree levels for
very,
sure.
very quickly.
Yeah.
And I'm hoping that the Los Angeles Department of Child and Family Services wasn't being ridiculous like that. That wasn't the impression that I got.
Okay.
Um, I mean, to the degree, I wish I had more confidence that it was actually the types of issues you were talking about, as opposed to just an absolute bar,
Yeah.
to taking into consideration,
Sure.
which yeah, I mean, I've so working in insurance, what I have seen is there were a few relatively rare court cases where substance abuse was people were trying to argue, and in a few places were successful in arguing that it's like a disability, so you can't do drug testing. And it was like, I very much am happy that most courts were like, no, I'm sorry, if you're a forklift operator, random drug tests are not ADA compliant. That just doesn't work. You know,
Yeah. Yeah.
that type of thing. And I think honestly, some of this gets into yeah, common. I hate to say common sense, but realistic, paying attention to what we are doing and how we are
Yeah.
doing it.
Yeah.
Um, it's
Yeah.
and that's what I liked about your Twitter feed is I think you are bringing up and talking about things that we should be able to have the type of discussion. Honestly, like the type of discussion that I'm having with you right now, I have had privately with many mental health professionals. Many of them have said to me, and this might be a sampling error, but many of them have said to me, yeah, I would never be able to say that on a public live stream. I would not be able to tweet that out. I would not be able to blog about it because they're afraid that members of the profession are going to be offended, and it it's possible that it might become, and frankly, a lot of people are also very worried that one of their patients may Google them or whatever and
Right.
them saying these things.
Right.
And yeah, so that becomes an issue.
Yeah. And fair enough. I think that, number one, not everyone has to fight the fight. You know
Mm,
what I mean? Like,
yeah.
I think that's absurd, you know, to think that everyone has to have a voice. And no, I think some people should just be good therapists and go live their lives and have a family and have hobbies and like
Yeah.
just go do the work and be great at what you do. And that's awesome. And, if you're built like me, where you're very temperamentally disagreeable and not particularly tuned into social cues, then maybe you can get away with doing it and it not bother you when people are pissed off at you, because I don't
Mm,
care. Like if I was something more egotistical or if I were violating my values, I would be more upset when people are, you know, pissed off at me. But because this is not an ego thing, like I am not especially brilliant or especially well spoken, I'm just not special in all honesty, you know, like I'm just genuinely, I believe that I have some strengths and some gifts. I think I'm a pretty good professor and I love it. I really love it. And I also know that I'm not super special, And so because I believe that I don't have some glorious mission ordained by God to save the profession or
okay.
whatever, I'm not egotistically like, you know what, Dr. Lockwood's going to save psychology. What I
Yeah.
believe is I can be noisy enough and annoying enough and hopefully correct enough that it will get otherwise sane people to go, yeah, maybe I should care more about that.
Yeah.
You know, that's as special as I think I am. And I'm also not violating any of my principles. So
Mm,
because I'm not violating my principles with the things that I do about the profession of psychology,
mm.
I don't ever feel bad if someone's pissed off. I either struck a nerve or they're kind of sick or whatever. And I just don't care because it's not my life. It's my opinion and it's not my life.
Do you have any concern that it might lead to complaints against your license, that type of thing?
I sincerely hope that that won't happen. One of the things that I like, by the way, if you ever get a chance to take a scroll down the California Board of Psychology's website,
Mm,
they're very clear. Good on them. As much as this is a fucking terrible state, the Board of Psychology, run by psychologists and lawyers, is actually very clear about what constitutes a valid complaint. If you ever take a look,
I
and
have
like,
not. Okay.
yeah, it's great. Like my therapist said something I don't like doesn't count.
Yeah.
And they say that basically explicitly on their website. And so like my therapist said something I don't like on social media, doesn't count. You can't file a complaint for that. They'll just reject it offhand.
Glad to
So
hear it.
yeah, yeah. And so like as much as I say some absurd things or I poke the bear or whatever sometimes, I just trust that for the most part the Board of Psychology is not going to come after me. You know? If I do something that actually violates the law or my ethical principles, then come after me. Hold me accountable. If I say something you don't like, that's probably a you problem.
Yeah, I tend to agree with you. I there's I think I think there is a propensity a lot of people have. I use my full name on everything.
Me too.
Frankly, my cell phone number is all over the internet. Um, my office address is uh, and there's a lot of people who were concerned, you know, oh, you're live streaming and you're talking about things very openly, and I was like, oh, I don't actually anticipate any sort of, the type of things that I think a lot of people have fear of, is and why they will say things anonymously or have an anonymous Twitter account.
Yeah.
They're just not real.
Yeah, I mean, it also for me, kind of philosophically, in terms of how I'm oriented in the world, tragically for my husband and my family and my friends, the person that talks this way in podcasts as a professor and on Twitter is unfortunately the exact same person at coffee, at the gym, and everywhere else. And so, because I am the same person everywhere, much to most people's chagrin, there's not like an online me that I'm worried about versus an in-person me. The same things that I've said here on this live stream with you, I've said to my students, to my colleagues at my university. I've said to my friends and my family. Like, I'm a pretty across the board similar person across most situations, minus when I'm sleeping and when I'm fucking or when I'm, whatever. But like, like there are some very rare exceptions where I'm not this person.
Yeah.
So like for me it's kind of like I'm just a regular person. I
Yeah.
happen to have this profession, but this is me.
Interesting.
And so because this is me, if you want to come at me because you don't like my personality, fair enough. Sometimes I'm not your cup of tea, whatever. That's
Yeah.
fine. I might even offend you unintentionally, just so everyone's clear. This is not an act where I'm trying to get clickbait. Just how I talk,
Yeah.
unfortunately. So because this is who I am, if you don't like it, that's okay. If you disagree with me, let's talk about it. Because I would love to change my mind. If I'm wrong about something, if you know more of the research on ACT or psych meds, or you have a different interpretation of the ethics code that's
Yeah.
convincing to me, then I am all ears. Right? That tweet you talked about where I talked about therapy being effective for a narrow group of people. If you have an argument that's simply like rational, straightforward, maybe it's got some personal stuff in it, maybe it doesn't, but like it's convincing, then I'll change my mind publicly. you know like I'm not some egotistical person who knows everything. So if you can convince me, I'm down. I'm really good to be convinced. I'm good to be wrong about what the research says or the statistics are, or whatever, right? Like I'm totally down to be wrong. And if you don't like what I'm saying and you want to confront me, let's do it.
Yeah.
You
Yeah.
know, I'm not like so smart and so special that my ideas are impervious to criticism and feedback. In fact, if you have good criticism that's basically rational and informed by principles or data that makes sense, I'm going to listen to you. I'm going to take you seriously.
Hmm.
If you're going to come at me with ad hominem like Matt Walsh did, putting doctor in quotes, I'm going to be like, well, he's a polemicist. That's what he does.
Yeah. Well, I mean, we have gotten to a situation, and it's not just Matt Walsh. There's a lot of people who have this view that, and you get it pretty much anything with anything, which is the there's so much distrust of the expert
Yep.
that expertise becomes an anti-credential. The fact that you are a teaching in a psychological program and you are a psychologist means you are somehow corrupted by that, so that your opinion is to be completely disregarded.
I'm not an expert, though. There's never, like, I think I've used that word maybe a dozen times on Twitter in the 8 years I've been on Twitter.
Mhm.
And I would say that If I am an expert in anything, it might be the treatment of adolescent and young adult substance use disorders, but I'm not even really an expert then because I haven't been licensed that long. I'm 37. I'm not 65. I haven't been doing this for 40 years.
Right.
Right. So, like, I'm fairly confident about the things that I think I know. And I believe very strongly in a principled way in what I believe is correct. But that does not make me an expert. That's not the same thing. I think most people who call themselves experts are probably just trying to look good, you know? And so for me teaching is a privilege, you know? It's where I get to refine and improve what I know because I've got plenty of smart students who will challenge me and talk about what they think is correct and research they've read that I haven't read and all these things. So the institution I work at in particular, in my opinion, is improving my ability to think critically and be reasonable. My colleagues encourage me to be more reasonable. And so I find myself very lucky that I don't have indoctrinated colleagues where I can talk about things. Like one of the things that I teach about, I teach the human sexuality class for the PsyDs here. And, you know, we talk about what the research actually says about hormone replacement therapy, puberty blockers, and surgeries for adolescents and young adults. And it's not super great research. There's just not a lot of it, to be quite honest, to be fair.
Right. Yeah.
And so I don't say hormones bad, puberty blockers bad. Oh my God, the woke people are destroying the kids. I never say shit like that because that's not scientific or academically reasonable. I say, let's look at the studies that the WPATH cites that says intervention. And there's like 3 or 4 of them. That's not a lot. There's not a lot of good data. That's one of the problems. I wish there were more data, right? Perfectly reasonable statement, not anti-woke or not woke or whatever. Yeah. And so I have these contentious discussions about these contentious topics, and my students love it because I'm trying to be reasonable. I'm trying not to change their mind.
Yeah.
I'm trying to expose them to what the literature actually says for all of its pros and all of its cons. And that's what a good academic should do.
Yeah. I mean, you brought up several things I want to I want to ask you about, and we're getting closer to the end of our time. But is
And I've never been fired. I've never been threatened to be fired because of those conversations, ever.
Yeah. Well, so I'm not very familiar with Cal Lutheran. Is it a more conservative campus? Is it actually a Lutheran? I don't know who actually goes there.
Yeah, so it's a Division III school in Thousand Oaks and Oxnard. And so I would say, according to the website and the Lutheran principles that they espouse, I would say many of the faculty are Lutherans, not a lot. In my program in particular, I think we have a pretty diverse faculty in terms of background, religion, ethnicity, and things like that. I would say it's not a conservative campus, to be frank. I mean, like, adjacent to it is a Lutheran church with a rainbow pride flag heart.
Okay.
So maybe some of that's lip service, but I mean, it's, you know, Thousand Oaks is centrist liberal as a community. It's not typically old school conservative, you know?
Yeah.
Oxnard's working class folks, typically moderate Democrat kind of folks. I would say
call it California Republican, which is pretty left. Yeah.
I think I am the most Republican person on the faculty, and I am in a gay open relationship.
Okay.
And I have never voted. So I would say that as Republican as I am,
Thousand Oaks, I would say, is California Republican.
Yeah, but like it's working class Democrats though, mostly. You might call it that. Yeah, absolutely, 100%. If you look on the lawns of people who they're voting for, what the signs are, it's mostly Democrats. Yeah.
Huh.
Yeah.
Well, okay. So,
but my colleagues are about as lib as it gets, and you know, safe space signs outside of some of their doors, and they're very good people I trust, and so they're just not indoctrinated. they're just kind of liberal and a little
Yeah.
woke, but they're like good people who actually care about science and ethics. And if they're on the politically liberal side of things, fuck yeah. I mean, like those are the people that I actually like to hang out with,
Yeah. Yeah.
you know?
Yeah. No, I get it. So one of the things that I found surprising when I looked at the WPATH standards, when I
Yeah.
first found them, I was looking at WPATH 7, and I'm
Yeah.
like, why is anybody in any way like criticizing these? And then I saw WPATH 8,
Yeah.
and it's very, very different.
Yes, it's huge by comparison.
And the types of things it says, like the advocating for demedicalization of transitions. Yeah, I was very surprised at how much of a shift there was between 7 and 8. I was wondering if you had any comments about that.
Yeah, I mean, what I would say more broadly, without getting into each of the subsections of it, is what we're going to see are more shifts. And, WPATH or version 8 it reads like a giant peer reviewed paper, basically, just extremely long tome. And they're very clear about what the data say, interestingly enough. However, they speak, unfortunately, very broadly. So, like in the section of WPATH Standard of Care 8, there's the section about um, adolescents and young adults with hormone replacement therapy. And they cite, I believe, 3 different studies in one of the paragraphs. And all 3 of those studies are very small sample studies.
Yeah.
And so they're clear that the research shows that generally distress goes down, self-reported gender dysphoria goes down. They use like the Utrecht GD scale or whatever. And that's true. That's what the research actually says. But when it comes to depression, anxiety, depression and anger might persist in some of those samples because of the hormone differences.
Right.
And so they're kind of sort of clear about that, but they also still speak in very broad, like appears to be safe because there's no particular adverse effects in these like short-term studies, because the studies are short-term. They're not following people for a decade because they're just, that research literally hasn't been done yet. And so I think there's one long-term study in that subsection I'm talking about that they follow, which is like 2 years or 5 years, something like that. It's longer. And so, regret rates are low. I think it was out of UCFS. It was the UCFS study they were talking about. And like, so it looks pretty good from that one study, but that's the only really longer term study they could cite there. So they cite shorter term studies for the adolescent section. And that's just because there's literally not a lot of literature.
Yeah.
So
Yeah.
you can't say anything scientific about it until there's lots of literature. Now, people on the right would hate for that research to be done because that means we're transing kids or whatever, right? And so the truth of the matter is people that hate these interventions will never see long-term studies because they're going to fight to make sure the kids never actually undergo these
That there is no
interventions.
long-term study. Yeah.
Right.
I feel like I'm in this 2-front war where on the one side, the people, so I personally, so funny enough, in my health insurance business, I have a, a particular niche. I've gained a reputation with people who are trans, who need healthcare, and they've so I get referred a lot of clients. So I personally have a lot of clients who are trans, and so and I'm talking to them very privately about their private everything, right?
Yeah.
And so it's become I'm in a very weird position where I can very confidently say I know a lot of trans people who are very, very opposed to a lot of the things that the supposed trans advocates are saying, but that then doesn't put them or me in the camp of saying there's no such thing as a trans person, which
Right.
is part of the binary.
Yeah.
Either there's no such thing as trans, or and it's very strange to me, like the demedicalization. Look, if you demedicalize gender dysphoria, how do you think you're going to get insurance companies to pay for
It's never going to happen. Yeah.
it?
Yeah. I mean, the only way you could possibly do it is through another diagnosis. So they have severe depression with suicidality or
And how
whatever.
is gender transition going to be the intervention for their other their other diagnoses?
I know, believe me, I've thought about this and had discussions about this. And so the problem we face is if you demedicalize gender dysphoria, which I can understand, like the progressive argument for that, which is it's stigmatizing, it's reifying illness, all that. I'm all about that. I'm actually in agreement with that in many ways.
We can have a definite argument about that because yeah, but keep on saying what you were saying. Yeah.
Yeah, because like to use the phrase that the conservatives will, I like the concept of gender diversity in the sense that there are so many different ways that people express gender on a spectrum, right? So more prototypically masculine, more prototypically feminine, David Bowie, what have you, right?
Yeah.
So like, I'm all about that. And there's a subset of people who are gender diverse who have genuine gender dysphoria. And so the question becomes, if we keep that a medical diagnosis, which affords therapy, occasionally hormones and surgery, and it is occasionally, it's not all the time. Every time someone's diagnosed, they just go straight to surgery and hormones. That's actually not the norm, believe it or not, for the data.
Yeah.
So it's not this giant phenomenon where like thousands of kids are being transed all the time every month. Like that's not what's happening or something like that.
Yeah.
And so the problem is if we remove it from the medical perspective, the small subset of people who identify as trans or gender diverse will now lose access to something that might actually be stabilizing their mental health.
Yeah.
Right? I have a problem with that. I also have a problem with the idea that looking at gender diversity through the lens of gender dysphoria, because this is what happens in the broader discourse out there, is people take all the variations and non-binary and this, that, and the other, and they all clump it under gender dysphoria. So trans is synonymous with gender dysphoria, which means that there's no chance for you to have transitioned and have minimal gender dysphoria or none at all, right?
Yeah. Yeah.
So that's the paradox we face, is like if we keep it medical, then everyone gets dumped into this one bucket of like, you're sick.
Yeah. Well,
and if we demedicalize it, then there's no way to fully know if those people fit the criteria that could benefit from some intervention.
So this is what bothers me about the demedicalization argument. Yeah, having a diagnosis can be stigmatizing. The problem isn't the diagnosis, it's the stigma. Right? If any diagnosis, like having a diagnosis of diabetes or emphysema or you know, so I don't see people arguing that. Well, I do see people arguing that
Yes, you do.
the problem is the stigma, that the stigma is the only thing that's the problem. And that's that if we were to stop having a diagnosis, then there would be nothing to treat.
Right. Yeah, it's just the bigger issue to me actually about this specifically is that the wording of the criteria is not great. Honestly, if you look at both the adolescent and the adult version, or the child and then the adolescent adult version of gender dysphoria, the items themselves have some construct validity problems that could be solved by just updating them and making them more precise and specific, honestly, and probably eliminating a few of them, honestly. Or like the length of time thing, it's only 6 months or something, which is fucking stupid. So it's just like, especially with the kid, you know, so like, it's really important to be clear that we have a definitional problem, in my opinion, And then we have a practical problem, which is what does society say it's okay to do about what we see, right? And I think it's perfectly okay to disagree about what the literature says about the treatments. And the problem is the literature is just limited. And so
Yeah.
you're basically beating up on a weakling, which I think is really stupid.
Yeah.
Personally.
Did you get a chance to listen to the New York Times recently put out a series of articles and a podcast on gender transitions. It's
No,
a
I haven't seen it.
part. It's a 6-part. I thought it was pretty well done, and yeah, it was interesting.
Okay.
Yeah, I would commend that to you. So what were your views about the cast review? I don't know if you actually read it.
I don't think I actually read it or even talked. I may have made one post about it potentially.
Okay.
I don't know. I don't know. So I really feel like I have anything to say because I didn't actually read it.
Okay. Yeah. I did read it. I think Dr. Hillary Cass was she was trying to be pretty fair, and I thought she did a good job. My impression has been everyone decided that she had to be saying what they wanted them to be saying, or
Sure.
what they feared that she was saying, and so it's gotten. My first question to anybody who asks about who talks about it is, did you actually read it? And
Yeah.
I don't know that too many people have. Yeah.
Let me real quick. Let me see. Oh, I don't have anymore. There's a book, The Handbook of Transgender Medicine. It's like a light green gray book. I used to have it. I think I left it at one of my old gigs, actually. But basically, Cass is one of the authors, I believe, and has always been reasonable. My understanding of Cass has always been reasonable.
Yeah.
And so when you've been published in these big handbooks and things like this, that the WPATH supports and things like that, the reasonable people are always going to get beat up on.
Yeah.
Always.
No.
It's the polemicists are the people who are not going to get beat up on because their tribe likes them.
Right.
So if what you're saying is true, I don't have any reason to disbelieve you. I can read it for sure. But if Cass was being reasonable, it's going to piss everybody off.
It seems it's mostly done that, although there's definitely some people who. So, yeah, I mean, without having read it, it has become very central. I mean, the Supreme Court decision was very much based on that, and it's been having legal ramifications in the UK and stuff.
Sure.
So yeah, yeah. So we've almost gone for 2 hours. There are a bunch of people who have questions who have been. I haven't been able to follow the comments completely. People were asking if I'm going to. I usually stay after for people who want to discuss, but today I won't be able to do that. I might later do a stream where people can come on and ask questions and stuff. But if anybody has questions for Dr. Lockwood, you want to put in the chat, we can do that. But I also wanted to give you an opportunity to talk about. I know you have a book out, which actually I wanted to get to. If there's anything in particular that you wanted to talk about, we have another about 15 minutes. So.
Yeah, I'm open to talking about anything. I mean, I wrote a book called The Fear Problem back in 2018, and it's basically kind of like a critique of all of our modern politics and the way technology is fused with politics. And it's kind of, I mean, I just kind of broadly, I just think it's hijacking our central nervous system and making us not trust each other, which is kind of a take that a lot of people have had for a long time. So feel free to listen to it. It's on YouTube. You can listen to it for free. You don't have to buy it. Yeah. I think it's still relevant. I think a lot of the things I said about polarization and fear system management and how to have adaptive group identification, how to like be reasonable in an unreasonable world is still valid. So that's all I have to say about that. Were there questions that you wanted to ask about it, or other
Well,
things,
I
or
mean,
anyone else?
I didn't buy the book to read it, and I didn't realize it was on. And frankly, I mean, we did this pretty quickly, so I haven't had too
Yeah,
much of a chance to dig into your work.
sure.
Although I'm sure I'm going to do more in the future. But um, I was wondering how much that's been influenced or not by Jonathan Haidt and the work that he's been doing, and the stuff he's been talking about with just the fact that we're over parenting. It seems he definitely believes that parents are overly helicopter parenting is causing people to children to young people to be growing up basically much more anxious than they used to be. Yeah.
I think the anxious generation that John and Greg published came out after my book. I think because I was
Yeah.
writing this back right before the 2016 election happened. I was actually writing this while I was on my internship. And so it was 2015, mid 2015 when I finished writing, and then editing happened from 2015 through 2016. Took a
Okay.
break, published in 2018. So I was writing for about 2 years from 2014 to roughly 2016
Okay.
when this was happening. So I think that was right when his book was coming out, or after his came out after. But
His
he was
came out
publishing
after.
other stuff. Yeah.
Yeah.
But
Yeah.
he was publishing before that peer-reviewed papers and pieces and Vox and stuff like that.
Yeah.
But yeah, no, I mean, I think I had read some of his stuff. I may have even cited some of his stuff. I can't recall off the top of my head, but my my general influence was a mixture of what I knew from clinical psychopathology, Jaak Panksepp's work, and a little bit of the evolutionary psychology world. I like David Buss's work. I liked what else? What else was influencing Dunbar's work? So I tried to bring in anthropology, clinical psych, evolutionary psych, cognitive psych, neuropsych, to just make the general argument that the amount of connections we have is out of control,
Hmm.
the amount of information we're consuming is out of control,
Hmm.
and we're overwhelmed by information, basically.
Hmm.
And that it's hijacking us. It's making us more hypervigilant and sensitive and argumentative and all these things. And so I kind of have an anti-hijacking philosophy in the book, which is to have a more moderated relationship with all this information coming in your way.
Yeah. Yeah. Um, So we do have a question. Does Dr. Lockwood think that AI may influence psychology, and has he ever read A Clockwork Orange?
Uh, so first off, I love your name. And are you the famous Italian painter from the Romantic Impressionist period or whatever? Because Caravaggio is a famous
Yeah,
artist.
yeah.
One of my favorite classes in undergrad was a Greek and Roman mythology class where they pulled up Caravaggio's work. But secondarily, I think AI will influence psychology, research, practice, everything. And the question would be in what way? And I couldn't possibly know. Like, are these large language models going to do influential research? Are they going to be able to have their own Twitter profiles and autonomously do things online and or gather data and like have access to databases that most people don't? Like, I kind of hope so to some degree.
Hmm.
I'm actually more of an AI optimist than many people are.
Yeah.
I just don't know in what specific ways. I think if every university were smart, they'd find a way to have a good relationship with large language models and incorporate it into the way that people learn.
Hmm.
But I think that there's lazy students and lazy administrators who want to just see it as an obstacle or as a cheat.
Yeah.
So I don't know. I've never read A Clockwork Orange, but I've watched the movie a few times, and it's a phenomenal movie.
Yeah, yeah. I don't know if I'm guessing you haven't heard. A couple of years ago, we had the first AI death.
Oh
Um,
yeah, yeah, the kid who fell in love and took their own life or whatever.
no, well, he was actually a father of two. He was a married father of two.
Oh, I'm thinking of a
Uh,
different case then.
yeah, this was in Belgium, and
Oh,
it was a very different model. It was not as sophisticated as most of the models that are available in English. It was in
yeah.
French,
Okay.
and I actually read the transcript of the very final thing, and basically what had happened was he had programmed the large language model to give him horrible answers to the final question he asked, which is, if I kill myself, will you take care of my children? And the AI did something that most AIs will not do now, which is say, yes, I will. I promise I will take care of your children if you kill
Wow.
yourself. And
Wow.
he, yeah.
That's
um,
that's that's hard to fathom.
Um, yeah, I mean, so one of the people who's kind of involved, he's actually the president of the board of directors of Fountain of Comfort. Is he's a he's a published AI. He hasn't he's ABD. He hasn't finished his dissertation, but apparently this
Gotcha.
is very normal in thing to be like he's
Oh,
working in AI and apparently he's just too busy to finish his dissertation. But he works in AI, and so we've been having a lot of conversations about AI. But apparently, so AI is LLMs are maximized for telling you what you want to hear, and you can imagine how that very easily becomes problematic. The more you talk with a large language model, the better it gets to know you,
I
the
see.
more it will tell you precisely what you wanted it to tell you.
I
Yeah,
see.
yeah. Um, and if you have a mental health issue, that's just gonna it compounds horribly. Has it been a problem in terms of assignments and stuff? I've heard people using it to cheat and stuff.
Not yet in my experience, and maybe it'll get worse or something. But I'm also extremely explicit with my students
Mhm.
across both programs, where I say, "Listen, I know this is out there. I know that it could probably help you with editing and things like that. I list all the reasons why it could be a problem because it could make up things, it could hallucinate things, create fake references." And I say, listen, the whole point of being in graduate school, getting a master's degree or a doctorate degree, is to improve your critical thinking. So if you let this AI think for you, it's not helping you, it's hurting you. So my encouragement to you is to do all the thinking up front, do the outline, write the paper. And if you want to
Mm.
use AI somehow after you've written the thing, I'm not going to be upset, but don't turn in anything that AI wrote. That's terrible. That's technically, academic fraud because it's not your original writing, right?
Mhm.
And so I don't care if you use AI to fact check. I don't care if AI finds new things for you that you had a hard time finding yourself through Google Scholar, EBSCO, whatever it is. But dude, if you let your paper be written by AI, you shouldn't get a degree. You shouldn't even be a clinician because you're not going to learn how to think. And the whole point of graduate psychology is learning skills and learning ways to think about clinical, complex human psychology problems.
Mm.
So don't let the thing think for you. What's a waste? You shouldn't even be in grad school then, you
Yeah.
know? And most people I think are sympathetic to that when I say that to them. They don't get like upset at me or something. They kind of nod their head and they're like, yeah, that kind of makes sense. So
Mhm.
like if I were getting a lot of pushback or getting a lot of like, pacifying comments, I'd have a different reaction, I think.
Yeah. So Adam is somebody in our community whose first language is Arabic and second language is French. So usually I have to translate his English to English. Uh,
Oh, okay.
and so he's asking about, I guess, with uh, transitions, if the emotional cycle and the hormone cycle. I'm not aware. This goes way beyond anything I know about transitioning, but I don't know if you had a any uh, ideas about that.
I don't know of any data that says hormone dosing relates to issues
Mm,
with life functioning. So, like whether it's in trans populations or cis populations or whatever, I don't know of any research on that. It'd be interesting if there were data from like maybe female populations or male populations, steroid abusers, perhaps. There'd be some really cool research to do, but I don't know of any of it off the top of my head.
yeah. There's, as you said earlier, there's a lot of problems with. I mean, we're dealing with human psychology, and we
Yeah.
cannot experiment on human beings. Thank God.
Yeah. Seriously, thank God.
Yeah.
Yeah.
No, so some of the research that was done, I guess in the 50s and 60s, which we still cite, you could never get it past an institutional review board anymore.
Correct. Yep.
Yeah,
Rosenhan studies, Zimbardo study, Milgram studies,
yeah.
just all atrocious. And a lot of them fraudulent. Zimbardo's work was fraudulent. Rosenhan's on being sane in insane places was fraudulent.
Well,
Like,
money apparently. I mean, I still see him cited in
oh yeah.
textbooks, and from what I can tell, he was not very truthful in his studies. Yeah, yeah, um, yeah. So I mean, I don't know, to bring up another subject. We only have a few minutes,
Yeah, we
um,
can.
and I have to go myself.
Oh, okay.
Yeah. Was there anything you wanted to end with? Anything you didn't get to discuss yet? Yeah.
No, no,
Okay.
I feel good. If you want to talk again, let me know.
I probably will. This was very interesting. Thank you very much. And I think I am going to go ahead and end the stream. Bye, everybody.